Hello, my name is Claire Johnson. I'm the Vivian Bullwinkle Chair of Palliative Care Nursing at Monash University. I'm also an adjunct professor in the medical school at the University of Western Australia. Prior to my current appointment as clinical lead for end-of-life care at a major health service in Melbourne, I was the manager of the Cancer and Palliative Care Research and Evaluation Unit at UWA for 8.5 years. I'm a nurse researcher interested in how we care for people at the end of life and how we can do this better for all Australians. I had the privilege of growing up in Esperance, a community classified as remote by the Australian Bureau of Statistics. Family members still live in Esperance and in other rural areas of WA. Given my own experiences and those of my family and friends around the state, I have a personal understanding of the disadvantages encountered by people living outside of Perth when they are seriously ill. My research shows that rural GPs are keen to care for people at the end of life. However, sometimes people who are dying remain in Perth where they have access to a wider range of services, but end up dying away from family, friends, and familiar places. I'm passionate about supporting rural patients to have access to the best end-of-life care possible. And this means supporting GPs, ensuring they have access to the resources, skills and support they need to provide this care. I know that fantastic end-of-life care can be provided in rural and remote communities. Both patients and GPs have told us about examples where patients were well managed, where their symptoms were well managed, and where the psychological and support needs were met through very cohesive, well-informed and coordinated health and social services. But how do we make sure this happens all the time and in all areas? This is where the Lishman Health Foundation stepped in and funded our small research group to find out from GPs themselves what care was provided and available for their dying patients, and what they feel is needed to ensure deaths are well supported in rural settings. We were very fortunate in receiving help from the Foundation to engage with rural GPs and GP organisations. The Lishman Health Foundation recognises that conducting research remotely, as we did from Perth and in my case Melbourne, has an added layer of complexity, and they are keen to see research succeed. Our research found that GPs try hard to support dying in the way patients and families want. But coordinating good end-of-life care is time-consuming. Symptom management and psychological needs of patients and families are sometimes challenging, and there are not always appropriate facilities and resources available. Importantly, we found that when end-of-life care preferences are discussed with the patient and family early, that is at least 90 days before the death, the patient is more likely to be cared for and die in their preferred place. Without this specific rural and regional research, we would largely depend on a picture of metropolitan practice only. To make sure that research which achieves measurable health benefits for rural, regional and remote communities continues and flourishes, the Lishman Health Foundation needs your help and support. I think the global pandemic has highlighted the importance of research to investigate the unique impact of health adversity on non-metropolitan communities and to seek specific solutions to address these unique problems.